just to spice it up, now it's a mitral valve. Okay, so this is a mitral valve intervention. Okay, so we know the possibilities around, so I think surgery is still king. Okay, so you can either repair the valve, do a tissue MVR, do a mechanical MVR, lots of caudal repairs, some fancy things that you guys actually do. But on the percutaneous side, definitely second best, okay? You can do an edge-to-edge repair, and that's getting increasingly common. I'm not sure I fully believe the wonderful data that was presented at our cardiology meeting saying that it was just an unbelievable treatment, because as you know, at the same time, there was another trial that came out of Europe that said it wasn't an unbelievable treatment at all, okay? But everyone got very excited, almost in tears, about the unbelievable treatment that was so good in that trial, and seemed to pick holes in the trial that showed it was not such an unbelievable treatment. But what is interesting, and what I do is when you get a valve into the mitral position, so either a valve-in-valve, a valve-in-ring, or a valve-in-Mac, the last one should be valve-in-Mac, which is a rather esoteric procedure where all the mitral angle calcification, which makes your job very difficult as a cardiac surgeon, you can use to hinge a valve. Okay, so those definitely need a big MDT. Okay, those are high-risk procedures percutaneously, but they can work in the right patient. Okay, so why has mitral technology not taken off? Because the aortic annulus is nice and firm, and it's an easy tic-tac-toe, noughts and crosses situation, which we've made quite easy with TAVI. I mean, the mitral valve is definitely Sudoku. There's a much more complicated situation. There's lots of other bits of string hanging off it, lots of sails. It's a very complicated valve, and actually just thinking you can anatomically stick in a circular valve is obviously a flawed idea. Okay, so this is a 61-year-old man. There's no old people at the Hammersmith these days. So he had a heart attack a long time ago, had a bypass many, many years ago. And at that time, it turned out, because it's always difficult to find the operation note from years ago, even in your own hospital, there was a mitral valve ring of sorts put in. We never quite worked out what sort of ring it was, but there was a ring put in, which was incomplete ring. He goes away for a long period of time, perfectly happy as Larry. Okay, and then he comes back, and he's getting really very breathless. So he gets admitted to another hospital, and they do a right heart catheter, and we're planning a left heart catheter. Now, they said the right subclavian stenosis prevented them doing the angiogram. Okay, now I want you to think about that. Okay, the right subclavian stenosis prevented them doing an angiogram. That makes me think they went up the right arm to do the angiogram in someone with a patent lemur or a history of a lemur. Insane. Yes, I have one time given the registrar a very severe Paddington Bear stare and then managed to get my catheter from the right arm to the left arm to take a picture of the lemur. Because I said, what is that big scar that's in the middle of the chest? And what on the x-ray are those ring things? What are they? And then he looked very bashful. But that's not what you want to do. So I think they ignored his bypasses, and then they decided they couldn't get up the right arm, and then they stopped. And they did the right heart catheter, which showed that he has quite a lot of mitral regurgitation. He had an MRI scan, which shows he's got inferior hypokinesia. The right ventricular free wall is tethered to the back of the sternum, and he's got probably an impaired ejection fraction on the right ventricle as well. The CT scan showed he's got functioning grafts and the right subclavian stenosis. Okay. Now, there's more background to this guy. He's a survivor. So he survived all that time with the surgery, but he's also got Hodgkin's, and he had that sort of special radiotherapy that was given to people with Hodgkin's where everything would get stuck down. And so I'm actually very impressed with the cardiac surgeon the first time around who managed to overcome what would have been the same amount of fibrosis the first time around and managed to get grafts that remained open for over a decade afterwards. So that's an impressive surgeon. So he's got paroxysmal atrial fibrillation. He's had some ablation for that and no recent AF. He found himself some iron deficiency anemia. That's been sorted out as well. There was a possible TIA. The ISEC came back within 5 minutes. No one quite knew what had happened. He's on antiplatelets. So along with that, at some stage, he got himself a pleural effusion, okay, and had himself a VATS biopsy. There is no cancer. And the recent lung review said, look, the breathlessness is not the lungs, it's not radiotherapy changes, those are all very stable. It's not the lungs. You know, when you go to multi-specialists investigating the same thing, hematologist says it's not the blood. The cardiologist say it's not the heart, and the lung doctor will say it's not the lungs. It doesn't help the patient because they've still got the symptoms. Okay, but the lung doctor said it's not the lungs. Okay, so he does have a degree of aortic valve disease. Okay, so he didn't have anything done to the aortic valve. There wasn't some fancy repair. And this is a TOE of his aortic valve, which obviously doesn't look normal, but neither does it look severe and ripe yet for an intervention. Okay, and if it was an intervention at 61, if he didn't have all the rest of it going on, he'd have surgery, wouldn't he? But with all the rest going on, with patent grafts, he'd probably end up with a TAVI. But that's probably not where the money lies, because that valve does not look that severe. Okay, the mitral we finally got to. So the transthoracic echo suggested really quite severe mitral stenosis. The leaflets are chalky. He's got probably at least moderate, if not severe, mitral regurgitation. You've known the MRI scan. I'll show you the TOE. Okay, and he's been through our MDT. Okay, so our MDT reviewed everything, said, look, yeah, it looks like a C-band annuloplasty, which doesn't get to the trigones. There may have been progressive annular dilatation, and the panel can comment on whether that really happens. Does the annulus sort of just, the ring opens itself out with the stretching of the atrium or the ventricle over time, so the annuloplasty doesn't work quite as well. Okay, so TOE of the mitral valve, you can see that the anterior leaflet is really, on this side, doesn't really seem to be opening all that well. There's some toughness, which is the incomplete annuloplasty ring as a sort of C shape. And then you can see it on a 3D echo there with some color. And there's a jet of vegetation coming back at us. That looks a bit more impressive. So both stenosis and regurgitation. So we did a CT scan. Okay, and the CT scan shows that it's a bit one of those challenging ones for a valve in ring, because the ring is not complete. There isn't a huge amount of calcium. It's quite large. So the way I describe it to my patients is that at the moment, we've got a 1 litre pot, a 2 litre pot, and a 3 litre pot that we can use for TAVI. If you've got a 4 litre pot, you can't have TAVI. So there's a limited range of kit that we can use. So 3-Mencio is a computerized software which gives us a bit more detail about what's going on. And the 3-Mencio software, you can model what's going on, suggested that you could do it. There's a risk of paravalvular leak. You're never quite sure exactly where the valve would land. And the left ventricular outflow tract, so this bit here, is what you really worry about, because there's no point in having a beautiful valve result and having no flow out of the heart because you've jammed the LVOT. That's equal to dead patient. Okay, I've rescued it twice, because it's happened twice to me, by ballooning the LVOT, and you can turn your circular TAVI valve into a more kidney vein. But you don't want to be thinking about that. That's a very traumatic procedure for the cardiologist, let alone the patient. So that's his medication. He's on apixaban. We've tried furosemide. Well, I know we like furosemide here. So we tried furosemide. He's been on smaller doses, bigger doses. It's making no difference to his symptoms whatsoever. And so the question, is anyone fancying doing an operation on him? The panel?
No.
Nope. So, I think he would be extraordinarily high risk. Yeah? It's redo surgery, all the grafts are patent. How do you get around all of those? Even if you did something thoracoscopic, everything's going to be stuck down. Radiotherapy plus previous surgery. So he's got very, very limited options. So he went through our MDT. They said, okay, if you think you can do it, that's fine. I was very nervous about this guy. And I said, look, ordinary TAVI in the aortic position, standard 5% risk now. That's 1% death, 2% stroke, 2% everything else. That's our data from 300 a year. Okay, this I do 5 or 6 times a year. Okay, and valve-in-valve, they're fairly straightforward. You know exactly where you can put the valve. Valve-in-Ring, bit more dodgy. Valve-in-Mac, really dodgy. Okay, so I said, look, I don't know how this is going to respond because your ring is incomplete. This is equivalent to a valve-in-Mac with not much Mac. I don't know where this is really going to end up. And he said, I'm dying here. I must have you doing something. And so it's the NHS. So we gave him a date. We cancelled it. Okay. We gave him another date. He sat in our hospital and then there was no bed. So he went home. Okay. But I did speak to him on that occasion. I said, look, this is a very high risk intervention. He said, if you don't do me soon, I'm going to be dead. Okay. That was his words. If you don't do me soon, I'm going to be dead. Anything. I said, what if I said it was a 50% mortality with this procedure? He said, I don't care because it's 100% I'm not living unless you do this procedure. Okay, so the counseling is key. He accepted up to a 50% risk. He knew what was going on. Okay, so medical therapy, I think, has failed. He's readmitted. His diuretics are working, but he really can't walk down the corridor. Okay, the ring is not complete, and redo surgery is unbelievably high risk. Obviously, he saw a surgeon face to face as well, and Professor Punjabi said nope, and he would do most things. Yeah, he's quite an operating surgeon. He said, I don't think so. We need to do a transeptal puncture. I don't. Some of the electrophysiologists still do blind transeptal puncture. The needle waves about inside the heart, and away it goes. Frightens me to death. I want to see where the needle is. Okay, so the needle is poking at the septum. So if I can do that, so there's the needle, and I have it on X plane. So there are two planes at 90 degrees to each other. So I know how anterior posterior I am, how inferior superior I am. So I'm in the ideally, the ideal position for mitral valve interventions is to be slightly inferior and posterior. So the mitral valve is a bit more anterior. So you've got a fairly horizontal axis. So those who are less experienced go, that's exactly where I want to puncture. And I said, that's because you've never done it, okay? Because actually what you end up with is a calcified septum, okay? And so you find somewhere in the middle which is safe, and then you get on with it, okay? So yes, I want to be inferior and posterior, but do I get that often? No, I don't. Okay, so the bubbles indicate where I've had to do a little bit of RF ablation on my needle just to get it through because it's such a tough septum, okay? So that's fine. Now, I show you this picture because what you don't want to do is put your wire into the aorta. Okay? So I saw that as an echo person is doing it. And I thought, that can't be anywhere near it. I've just done it with X-plane. And of course, it's because it's either in front or behind. Yeah, because the TOE has a depth to it. So it's not really in the aorta. Okay, we're carrying on with our procedure. But that really is in the appendage. Okay, so our wire is in the left atrial appendage. So once I've crossed the septum, we have to make sure we aren't poking great big fat sticks into the left atrial appendage. Otherwise, we'll have to call our surgeon to do an emergency operation. They're not very happy with us when they said no to the elective operation. So we're going to avoid that as well. So it's a long procedure, but the summary of it is we need to dilate the intraatrial septum to allow our kit to get across. So we balloon the intraatrial septum. Okay, so that's the ballooning. Now, I did a LAMPOON procedure here. The anterior mitral valve leaflet is quite calcified and could act as a lid that goes straight across the left ventricular outflow tract. If we put a slit in the anterior mitral valve leaflet, so instead of being a sail, it's like that, then it may be that we'll have some blood flow going through anyway, even if we're getting a bit close to the intraatrial septum. So this came out of America, okay, electrosurgery, okay? So we can poke a needle through the base of the mitral valve leaflet. Okay, you can see that there's some kit coming along and a snare sitting in the left atrium. And what we're going to try and do is poke a wire through the base of the anterior mitral valve leaflet, snare it in the left atrium, and now we've got a rail. If we electrify the rail and pull back out of the aorta, we slice the mitral valve leaflet, okay? This is a 4-hour procedure, okay, all of it. So this is, I've abbreviated it. But what we want to do is also remember, I've got 2 catheters to the aortic valve. We started with an abnormal aortic valve. I've got one catheter that's going to sit on the anterior leaflet so I can poke my wire through. Another catheter, which is the snare, that's going to catch my wire once it's through. So I've got 2 catheters through. Now, he tolerates this remarkably well, but you can imagine that some people might not. And I think he tolerated well because he already had moderate AR. So he's used to AR. If you take someone with no AR and give them AR, they don't tolerate it very well. But if you've got someone with moderate AR and it becomes a little bit more, they usually tolerate it quite well. So the bubbles indicate when I've just done the zap. Okay, and so I've zapped the wire through, and we're now into the snare. And there's a nice, so watch this 3D echo, because there's a snare in there, and then as it repeats again, you grab the wire and pull it. Okay, so that's the wires being pulled from the left atrium back into the left ventricle to create that loop. I don't know whether you can appreciate that in, just watch this space here. Okay, we get to the start, there's the loop, grabbed and pulled through. Okay, so that's the snare. Now, before you actually slice your mitral valve leaflet, you better be sure you can get your new valve in, because you're about to give this guy torrential mitral regurgitation because you cut up his anterior mitral valve leaflet. So it's very important to get your valve into position before you do your tear. Okay, otherwise, it's often quite difficult to get the valve into the right position. You don't have half an hour to position it at that stage. You've got about 2 minutes. So the valve is already in position. You can see how difficult it is to see the ring. Yeah, it's just a thin line. and you have to try and align it. And there's often no absolute firm line because it's a bit twisted. So there is no one plane which gives you into the page view, as was the case here. So we've sliced the mitral valve, and then we're deploying the mitral valve. I don't do it with rapid pacing. The valve doesn't move around that much, and I'm doing it very slowly. And I'm going to labor this one, okay? It's going to take about 60 seconds. And we're going to watch it for 60 seconds as we slowly pull back and forth, trying to make sure it's their ideal position. About 80-20, 80% into the LV, 20% into the left atrium, trying to get it into the right position.
Are you doing this with the surgeon too?
No.
Scrubbed in? No, you do this yourself?
No. I mean, the surgeon, you know, there's an amazing skill base, but they're not going to add anything in this party. I know Neil Moat got into TAVI and did lots of TAVI, which is fine. And the Plymouth group actually have TAVI done by the cardiac surgeons. They lead the whole group. No problem. Okay. Our surgeons never quite got interested enough. You know, one of my senior surgeon who joined the TAVI program, he said, look, I'm not going to catch up the skill base you have with catheters. So what am I in this game for? Because this is going to be increasingly a catheter-based technology. You know, so even the access, it's venous access, it's 18-20 French, but 2 ProGlide sutures percutaneously is what we're doing. So I don't know whether this has gone round once already while we were talking to actually show the deployment. But it's a slow deployment. Now the problem is we've locked it in position, it's not fallen out, okay? The red arrows indicate that it's on a bit of a tilt. At one side, it's perfect, 80-20. On the other side, it's a bit more like 50-50. And you can't avoid that. So sometimes you get away with that, and that's absolutely fine. And there's no LVOT obstruction. We can do a pigtail catheter and check. So we think, okay, no LVOT obstruction, the valve hasn't fallen out. I'm amazed. I'm now less amazed. Okay, so those who are not used to looking at echo will see that there's quite a lot of color. Okay, so you should, even if you don't interpret echo, that shouldn't be there. But what's happened is that the valve is so much into the left atrium, you're getting what's called a supraskirt leak. The valve has a skirt on it, but if the skirt is too far into the atrium, then you've got a jet that can go from the left ventricle through the stent struts into the left atrium because your valve is just too far. You're still hemodynamically quite stable, but this obviously we can't leave. So what do? Well, we put a second valve in, okay? So we've now got a rigid skirt, okay? And we can put a second valve in, which is going to deploy, and that's now deployed, okay? I inflated it a bit more with a little bit more volume. And again, no LVOT obstruction, and now our echocardiogram looks like that. So now we've got no mitral regurgitation, the LVOT looks okay, and he's on a little bit of fruseline. I would say amazing, and I love seeing these patients in clinic 3 or 4 weeks later, okay? Except for this guy. So he came back and said, look, I feel rubbish, okay? I'm not feeling good at all. This procedure's not done me any good whatsoever. And I said, hang on, let me think about that for a minute. You told me that if I didn't do it within the next few weeks, you were going to drop down dead, okay? So are you saying you're at death's door? He said, well, no, I mean, I walked into the hospital, but I just don't feel right. And I said, okay, well, you might be deconditioned because you had that for 6 months. Is it AF? Nope. Okay, is it the lungs? Lung team say it's stable. Is it the heart? The aortic valve is moderate. The LV is mildly impaired. The mitral valve is completely pucker now. Is it the psychology? Because then he came back a second time. So I saw him, I did some more tests, did a TOE, and then brought him back. And he said, I called the ambulance. And as the ambulance was with me, your valve clicked into the right position. I now feel a lot better. And I said, I'll take it. Okay, I think I'm not sure what happened. It's certainly my valve didn't move. Okay, but I'll take it. I'm glad you're feeling better. Let's hope that this thing actually continues. So it wasn't the most successful story in terms of him. He's just still slowly getting better. And I think there's an element of brain and there's an element of deconditioning. But again, it illustrates that this was a very team-based approach. If I worked in a center where the surgeons would kill me if I did anything odd, I'm not doing this, am I? Okay? If I'm working in a center where there's good MDT and we're supported in doing these really very high-risk cases, that's fine. Even now, there's still an element of those outside of the valve structural team think we're mad. Yeah? So you do a 90-year-old, you're absolutely insane. What are you doing? I said, yeah, but if that was your granddad, you'd want me to do it. Yeah, so when we were on the BBC sort of hospital program 5 years ago, he was a 98-year-old. He lived for 4 years more, and the family was very grateful to have that quality of life with that guy, which is what you want to do. I'm not trying to make him live longer, but live better and then live longer as well. That's a good bonus. I think he'll live longer with that valve in. It was a 4-hour procedure. It created some thought process. I've shown you the LAMPOON procedure, which sounds mad, doesn't it? But then when TAVI first came out, everything was mad. How can you hang a valve on a bit of chalk with no sutures percutaneously and expect that to work? But it does. So that's my third case. Any comments?
Well, superb result, and great treatment. Just one question, just out of interest, if this man's aortic valve deteriorated significantly, how easy, having done this, would it be to place a TAVI?
Oh, very easy. So TAVI is going retrogradely. Yeah. I know I can get every catheter retrogradely, and so I considered just doing the TAVI. We've had him back at the MDT, and I said, he's not got better. This aortic valve is not right. We're going to end up doing it. Why don't we do it now? And they said, well, it's not quite severe, but the AR might be the problem, because AR is not well tolerated by ventricles that aren't quite right. And so if he doesn't get better the next time I see him, I'm just going to do a TAVI. Yeah. And the TAVI, the only problem will be the conduction system, because I'm going to be squashing in between two. So I've told him already that if we do that, he's going to end up with a pacemaker. It would be very unlikely we'll get away without the pacemaker. But it won't affect the LVOT because we're much higher than that. And the procedure will be perfectly straightforward. It's like every other TAVI. I wouldn't even do it under GA. It would just be a local anesthetic with a bit of sedation procedure.